I'm Dr. Ahmed Mordi, consultant intervention radiologist at Royal Bahrain Hospital. It's my pleasure to be invited by Dr. Wiam. Okay. It's my pleasure to be invited by Dr. Wiam to his great congress. Okay, let's start about a very novel technique for the thyroid nodule treatments that has the announcement across the media nowadays. It's called the thyroid ablation for the benign nodules and for malignant purposes. I have no conflict of interest. Before 300 years, the physicians used to listen to the body sounds like this, and it was very weird. Dr. Lanik, who invited the stethoscope, has the chance to change this practice to nowadays. Jumping 200 years to Dr. Röntgen, he discovered the effect of X-ray on the human bodies, and this is the picture of his wife's hand with the wedding ring. After that, in the mid 20th century, Dr. Dotter was seen running in the corridor of his institute towards the X-ray room, putting a small tube inside his hand and jumping under the X-ray machine to take an image of what's happening inside his body. He was injecting a contrast media inside his body, and it was the very first catheterization procedure in the whole era. And this is the picture of the very first lady that get the first angioplasty ever by Dr. Charles Dotter. He was very weird and he was very exotic to build this practice and to build the science of intervention radiology. So intervention radiology is a very sophisticated specialty and very high-end specialty in the medical practice. It works like a Formula One. It needs a supercar. It needs to be a Formula One driver. It needs a Formula One team to build your practice. This picture from the cath lab while we were working to occlude a varicocele in a patient. We are intervention radiologists, and we build our practice on the European Society standard of practice and American Society standard of practice for intervention radiology. So, what the intervention radiology? The intervention radiology, very simple concept. It builds every procedure on what's happening inside our bodies under a camera. So we have a lot of cameras, ultrasound, we have X-rays, we have CT, MRI. We can see what's happening inside our bodies during treating or solving a problem inside the body. Through 1 to 2 millimeters skin hole, we can do major things. We can treat strokes, we can treat fibroids, we can treat liver cancers, lung cancers, kidney cancers. We can open occluded vessels. We can occlude bleeding vessels through 1 to 2 millimeters like this axis. We can treat non-vascular problems. We can treat vascular problems all over the whole body. We work in the heart, in the vessels. We work to treat cancers in the brain. We can treat fertility. We can treat the vascular access for dialysis. We treat a lot of things. And we work in a multidisciplinary teams. And we can do a lot of things together. So, I believe in evolution, but what's happening for the thyroid surgeons? The thyroid surgeons are building their practice on this scar, but the ladies are refusing to go for this surgery because of this scar. So you can see here the difference between this scar and this opening here. It's a hole about 1 millimeter. This is by intervention radiology to treat the same thyroid nodule. For this purpose, the surgeons tried their best to avoid this ugly scar in the neck by doing this surgery at the nipple level, transoral, transaxillary. And nowadays, there is a new procedure called thyroid ablation. Actually, it's not a very new, it's about 20 years ago. And there is a lot of types to get the ablation for the thyroid nodules. By thermal or non-thermal ablation. This is called the high intensity focused ultrasound that focus the ultrasound waves inside the nodule and burning it without puncturing the skin. The ablation has two types, thermal or non-thermal. The thermal is applying heat or freezing inside the thyroid nodule or any body tissue that we need to destroy. The non-thermal ablation we can achieve by alcohol ablation, sclerotherapy, polydocanol, or sodium tetradecyl sulfate injection inside the nodules, and the perinodular vasculature we can get by we can achieve the non-thermal ablation by high intensity focused ultrasound or reversible electroporation, or this is some kind of electricity that is applying to the tissue. Thermal ablation, the favor is gone to Dr. Baik from Korea. He built this practice, minimally invasive practice, started by laser and radio frequency, and nowadays there are the microwave ablation. So, how we achieve the effect of ablation on the cells? For the ablation, we need to damage cells and irreversibly. So we need to apply a very localized field of heat inside the nodule under target of 60 to 100 degrees to achieve the coagulative necrosis that will initiate a process of phagocytosis. If we are exceeding 100 degrees, a carbonization will happen. What is the carbonization? The tissue will be like a charcoal. The tissue will be like a charcoal, and the phagocytosis at this point will not work. How we choose the thermal ablation? We have three modalities. We have radiofrequency ablation, laser ablation, microwave ablation. The radiofrequency ablation is not suitable if the patient has a pacemaker or cochlear implant or has metal joint or prosthesis like this, or the patient is pregnant or lactating. So the microwave and the laser will be the best for him. Before our procedure, we have to know a very sophisticated details about the anatomy of the danger zones of the neck. There is what's called a dangerous triangle. It's between the trachea, the esophagus, and the thyroid. This triangle may contain the recurrent laryngeal nerve, vagus nerve, or another variants of nerves. Nowadays, the concept changed from the dangerous triangle to the dangerous zone because there is a variance of the neural anatomy in the neck. Like here, this is a dangerous triangle containing the carotid artery, sympathetic chain, recurrent laryngeal nerve, variance in locations, and we have to avoid this, and we have to protect them during ablation. So, is our practice in thyroid ablation is working on guidelines? For sure. The first guidelines came from Korea by Dr. Baik and his group in 1917, and the guidelines are very marvelous. They give a very detailed idea about the indications and the effectiveness of the procedure and the needed treatments and how to select for the treatment. In 2020, the European Thyroid Association, they published their guidelines in relation to the thyroid ablation and comparing them with the surgery, and they stated that the thyroid ablation may be the alternative for the surgery. Still, in Europe, the surgery is the first line of treatment for thyroid nodules. But in the Korean group, the first line of treatment becomes thyroid ablation. The North Americans, USA, they came very late after 20 years Actually, they banned the procedure about 20 years because of the complications that happened in the very first steps in USA. After that, they came again. And this consensus coming from the National Institute for Health and Care Excellence about the microwave ablation for the thyroid benign nodules, and it's very good to read this article. So the Italian and the Koreans consider the ablation for the thyroid nodule as the first line of treatment, and the European Thyroid Association consider the surgery as the first line of treatment. So what we can do before ablation? Before ablation, the patient comes to the endocrinologist to check for his neck swelling, and the endocrinologist send him to after clinical assessment for ultrasound assessment and fine needle aspirate. Actually, in our institute, Royal Bahrain Hospitals, we stopped the usual practice for fine needle aspirate and biopsy and cytology by the conventional techniques, sliding and microscoping. We changed it to liquid-based cytology, and I don't know if any of you consider this in his practice in his institute or not. Liquid-based cytology has many advantages. It maximizes the cells inside the sample, and it runs very automatically without a human interference. And we choose our patients according to Bethesda classification. We choose the benign approved nodules, category 2. Category 3 are excluded. Other malignant categories are shifted to and referred to surgeons. So when to ablate? We ablate the nodule if it's solid, but it's less than 30 cc. Actually, we can ablate bigger than 30 cc, but the patient will get 3 to 4 sessions. And we ablate the mixed nodules with a solid component bigger than 20%. Below 20%, we will go for alcohol or sclerotherapy ablation. We ablate the autonomous functioning nodule, post-surgical nodule recurrence. We ablate the parathyroid functioning adenomas, the macropapillary thyroid cancers of classical type, not for bizarre type. And for sure, if the patient cannot sleep and cannot go for anesthesia, we are here. So, the thyroid cancer. These guidelines came from the European Society of Intervention Radiology and the European Thyroid Association in 2021. And the most important point of them, when not to ablate the cancer, the papillary cancer. If the cancer has taller cells, columnar cells, or abnormal non-classical type of cells, or we cannot ablate. If the cancer is multifocal inside the thyroid gland or near the trachea, subcapsular, we cannot ablate. And we cannot wait also for surveillance. If the thyroid is metastasized already, or there is regional lymph nodes, or there is some mutations in the genetic assessment, or some specific genes like TRT promoter gene, we cannot ablate these patients. So, in the European Thyroid Association, you will find here that the most acceptable type of the cancer to be ablated is a papillary carcinoma with a classical variant only. Any atypical variant like columnar cells or one of those, we cannot ablate. After 3 years, they came to assess their treatments by ablation. Dr. Baik and his group from Korea, they told us that the ablation is very safe compared to the surgery, and we can proceed for ablation. And here you will find that a lot of institutes participated in this study. And here you will find this is the only prospective study, and the whole others are retrospective studies. And here you will find that the whole institutes are applied multiple sessions of ablation, except this one is coming from Korea. After 3 years, they found that the complete shrinkage or near complete shrinkage has happened. Nearly about 98% of shrinkage of the original volume size was achieved, and this is a marvelous results. After 3 years, also the microwave ablation came to front with these results, and it's almost comparable to radio frequency ablation. We use the microwave and the ablation procedures to ablate the solid and the mixed nodules. Actually, the ablation is very good technique in the mixed types of nodules, and it hits more than 85% of success and shrinkage. Here, this study is comparing the radio frequency and the microwave ablation, and they are almost the same in the results after 3 years. So, concerning the autonomous functioning nodule, I have one point only here. From my experience, when I come to ablate toxic nodule, I should work with endocrinologist in a very close fashion, because this nodule will be damaged, and the follicular cells containing thyroxine, it will pour its thyroxine inside the blood of the patient. Within 72 hours, the patient may go into thyroid crisis. So please, if you found a thyrotoxic nodule for ablation, please work with endocrinologist. So how we plan for the ablation? Before ablation, we have to get a very sophisticated details by ultrasound for every single patient in relation to his neck anatomy, especially his nerve pathways, and we have to map his nerves inside his neck. Here we can find the vagus nerve. The normal vagus nerve location is to be at 3 o'clock or 12 o'clock. Actually, in some patients, we can find the vagus nerve running here at 9 o'clock or at 7 o'clock, and this is very dangerous to damage this vagus nerve. And the sympathetic chain also, the usual location for the sympathetic chain is in the lateral aspect of the carotid artery. In some patients, we can find the sympathetic chain in the medial aspect of the carotid artery, and we have to control these nerves away from the ablation. This is one of my patients. Before 7 years ago, I was starting my practice in the thyroid ablation. After the procedure, he came to me at night telling me, doctor, I have, my face is sweating in this half and not in this half. So this was Horner syndrome for this patient. What's happened for this? He is very good now. Nothing happened after 1 month. This is because I was building my knowledge and my practice in the very first steps before 7 years. Now the complications are less, but it's still there. So we have to protect the recurrent laryngeal nerve of the patient by assessment by ultrasound. Before that, before 10 years, they were assessing the vocal cords by flexible endoscopy. Now we just do ultrasound assessment of the vocal cords, and it's a very simple technique. It takes about 30 seconds only, and we like this. Okay, you see the vocal cords here; they are moving, and we should assess the vocal cords before the procedure, during the procedure, after the procedure. So also here we have this article. It's a very good article to check for the risk assessment. If we found a nodule like this, it's subcapsular in the medial aspect related to the dangerous zone, we have to dissect this nodule from the nearby tissues. Actually, we dissect by fluids. So what will happen if we ablated or we hit a vocal or we hit a recurrent laryngeal nerve? Just do not panic. It can be happen. It can be from the local anesthesia, which is the commonest cause, or If it's from the ablation, we have to inject a mixture from 20 cc of cold dextrose with 20 milligram of methylprednisolone in the tracheo-esophageal groove, like this. I don't know, it's converted. Okay, here. Yeah, like this. We inject here the trachea, here the carotid, and this is the dangerous triangle. We inject directly inside here dextrose, cold dextrose with methylprednisolone. Within 5 minutes, the voice will come to its normal baseline again. Okay, so this is a nodule, and this is what's called hydrodissection. We came here and we inject local anesthesia and the fluid because the capsule of the thyroid is the only sensitive part of the thyroid gland to pain, and we have to protect the patient from pain. This is a painless procedure. If the patient felt any pain during the procedure, there is something wrong happened. You have to stop and you have to check what's happening there. What we use for the hydrodissection and what's called the tumescence, we use dextrose because it's suitable for microwave ablation, for laser, and for radiofrequency. For the radiofrequency, saline is not suitable, but suitable for microwave and laser. And actually, both of them are vanished away within minutes, after 5 minutes. So I learned this from a surgeon colleague who told me that we can use colloid fluids. They are slowly absorbable and they last more than 20 minutes in the tissues. How to maximize our results? We have to focus on the nature of the nodules. If the nodule is a sponge of sponge form, this is the best candidate for the ablation, and the volume reduction rate will be very quick. Within 1 month, it will shrink more than 85 to 90%. If the nodule is mixed with a solid component bigger than 20%, we can ablate. If the autonomous functioning nodule has a peripheral vascularity like this, we will ablate, and we have to ablate the feeding vessel to the nodule. Otherwise, it will come again within 1 to 3 months. For all our patients in Royal Bahrain Hospital, during the FNA, we do what's called a shear wave elastogram. If the patient has a benign nodule, but the shear wave fitness is above 60 kilopascal, we will not go for ablation because the volume reduction rate will be very slow. Here, we have to plan our procedure before the procedure, and we have to set the parameters in the machine. We have to sketch, and we have to choose the best camera for every single patient. This video, every single video is coming like this. Okay, we are using what's called the moving shot technique. We ablate till the air bubble appear, then we pull back the needle, and we repeat the procedure again. Thanks to liver, we learned a lot of things from liver ablation during our training in the residency program. And this is one of our patients at Royal Bahrain Hospital. This is the air. If you can notice, this is the air. Here, the air appeared like this, and we are pulling back the needle and the air coming out. And we have to complete this segment also. So what we are doing after the procedure, within 30 minutes, we apply cold fomentation. After 30 minutes, we invite the patient for a cup of tea and some biscuits. Before discharge to home, we check for the last time the dressing, and we just prescribe a simple analgesia. Then he can go home safely driving by himself. The whole procedure is running under local anesthesia. For the follow-up, we use this formula. We measure pre-ablation volume and post-ablation volume at 1 month, 3 months, and 6 months. And we use this formula to measure the volume reduction rate. Actually, the success is coming if the shrinkage is 50% or bigger. Actually, in real practice, none of my patients is hitting 50%. Actually, all of them, they are hitting bigger than 70%, and this is depending on how to choose your patient. So if you have a shear wave above 60 kilopascal, do not ablate. This is a very important slide. For this patient, they are the same nodule. This nodule before ablation, this is after ablation. If this patient went to diagnostic radiologist for ultrasound without telling him, I have nodule that was ablated 1 to 3, 4 months ago, he will consider it according to Thyroid's classification. It's a very malignant nodule. And you will scare her, my lady, you have some cancer inside your thyroid, just to go for a surgeon to remove it. Actually, this is normal picture. This is normal picture after ablation, and every diagnostic radiologist should know about this. For that reason, the Diagnostic Radiology Societies of North America and Europe, they published what's called the thyroid post-therapy or post-treatment, and it's totally different from this thyroid. So please, if you have a patient with a thyroid nodule that was ablated and you received a report that stated it's malignant, because and it's malignant, please just call the radiologist and tell him it's ablated nodule, and send the patient back to him to reevaluate his assessment. So, if the patient has a nodule bigger than 30 cc, the patient will need another ablation. When to ablate? This article came from China, and its answer, it was after 6 months from the first ablation, you can ablate, because the complete necrosis of the tissue will happen only after 6 months. Before this, just apoptosis and coagulation is happening. The ablation will add nothing for this nodule. Before 6 months. A very repeated question from every single patient: does my nodule convert to cancer after the procedure? This research came with the result, and they stated that the ablation has no carcinogenic effect at all on the nodule or the normal tissue of the thyroid. So, after this, does it work? Yes, of course, it works. Here, you can see this nodule, the volume. We are depending on the volume. We are not depending on the single dimensions. We are depending on the volume. Here, you will find the volume about 14 cc. After ablation by 1 month, it becomes about 4 cc, with a volume reduction rate about 70%. This is the same patient. Here, you can find a nodule with a cosmetic score 4. The cosmetic score is 4. And here, the patient has the procedure through this scar, and after 1 month, comes without any bulging nodule. What else? We have what's called thyroid sclerotherapy, and what's called thyroid artery embolization for these huge thyroid nodules. We can embolize the feeding thyroid artery. Within 1 month, the patient will get a volume reduction more than 80% through this pinhole from the hand. We can treat this thyroid from this pinhole, skin hole. Okay, and for sure, the parathyroid ablation, we can treat the functioning adenomas. And the future will come to the treatment of cancer, of thyroid cancer. So the intervention radiology, the practice without a scalpel at all, this is a very simple set. You need ultrasound and the needle and local anesthesia, and that's it. Here, remember, we are not surgeons. We are doing our procedure without a scalpel. It's office-based procedure. Within 30 minutes, you can treat thyroid nodule, and the patient can go home within 1 hour without removing the thyroid and without depending on thyroid hormone for life. If you have a patient and he is asking for some information, you have to give him this article. This is very suitable for patients. So the thyroid ablation, we are working in the Thyroid Center of Excellence with Mr. Chairman in Royal Bahrain Hospital. The patient came to Dr. Wiam, and he was assessed by Dr. Wiam clinically and by ultrasound to go for fine needle aspirate. He is benign. He will go for thyroid ablation by me. For follow-up, he will come again for me and Dr. Wiam. So intervention radiology is giving you a very extraordinary, fine and valuable treatments for major things. Okay, and thank you.